I've just had one family whose child, no matter what we do, seems to have exacerbation. I see them 2 days later, and I just wasn't sure whether they were adhering to what we have on the asthma plan, so I just want to make sure I've got it right.
So I think the important thing is just to use an age-appropriate asthma plan, and the one from Asthma UK is quite nice for slightly older children. So the first bit is really about, like you were saying, their daily management, because they haven't got their daily management correct, and that's why they might be getting lots of exacerbations. So I assume that this child is on a preventer.
And then he's already on the Seretide.
Okay. Do you know what strength of Seretide he's on?
It's been increased to the highest tolerable strength.
Okay, so he's on Seretide 250 maybe?
250 now.
So maybe it's always maybe just put in brackets what strength he's on. So it's just then stressing to them that they take, one puff in the morning, one puff in the evening. And I think the colour is really important, because often they'll probably come into you not telling you what the name is, but more what colour they're taking. Does he take anything else?
The salbutamol. And
so his salbutamol will go under the reliever inhaler.
Because it's hay fever season, he also got some rhinitis that he takes tyrosine.
Okay, so I think it's really important, because often they don't realise that if they don't control their allergic rhinitis, then their asthma is going to get worse. So you could put in that they should take their cetirizine, and then you might put, rather than a dose, but how many tablets that they take.
So just one tablet once daily.
And other medications you may put there is if he, for example, is on a steroid, a nasal steroid, or if they were on Montelukast or something. And then has he done a peak flow?
The last one, it wasn't his best. It just came back from
so maybe when he comes in, when he comes in for you to go through this, and he's feeling a lot better. Because, like you pointed out, it's not great to do it when they've just had an exacerbation. But when they're well, it's to do their best peak flow, which of course you want to make sure is somewhere in keeping with their height, but not necessarily always that number, but it's what their best is as well. Great. Do you know if he has trouble when he's doing sport?
Yes, he does.
Okay, so he might need to take a bit more extra reliever inhaler before. So we usually say between two puffs or so to take, and that's quite important, because you might communicate this plan with school, and that lets the school teachers know as well. And then the next bit really goes on to, as you said, so for him, he starts to get unwell. And actually he might be able to do quite a lot before he gets unwell and gets into hospital. So the second bit of this plan really just goes through recognition of when he's getting unwell. So that might be things like he's waking up more at night, his chest is starting to hurt, he's actually wheezing, because actually on a day-to-day basis he shouldn't really be wheezing, or he's taking his reliever inhaler a lot more. So on this one it says more than 3 times a week, which is very fair. And it also mentions about the peak flow. So if he's the type of child that, or family that you think parents are going to get him to do his peak flow, it's worth putting in a number, because sometimes numbers are much easier for parents to and children and young people to understand. So here I would say if it's more than, if 75% of their best,
that's what
is
the number I would go for. Yeah.
Okay. And then if they are getting worse, if they are having these symptoms, what they should do. So I think it's really important to stress to them that they should continue taking their preventer inhaler, because actually that's probably what's keeping them well, but also that they can take more of it. So how many puffs would you suggest?
Up to 10.
Yeah, so that was what we would say, up to 10 puffs of their blue inhaler. And I think the big thing to point out is every 4 hours.
Yeah.
If they're using it more than every 4 hours, then they really should be seeking.
Some families do it almost every hour.
Exactly, and that's when, by that time. And also you start to wonder whether they're actually having effective inhaler medication given to them, because sometimes they're not using even their spacer. So just to make sure that they remember that they should definitely have their spacer. And then just to stress that if they're not getting better and they're doing this and they've been doing it for more than 24 hours, they really do need to come and see you. Okay, great. And then the next bit is really if they are having an acute attack. Often parents recognise this quite nicely, and especially young people do as well. So if they're breathing really hard, I think one of the things that's quite nice to point out here is if they're not able to talk, because often that's how we measure it. When we recognise, not completing sentences, only using 2 words, and then also their peak flow. So if it's definitely less than 50%, then and then what they should be doing. And here they say they can take it every 30 to 60 seconds. I would say this is when they're having a very, very acute attack. So they may do this for a little while and feel better, but either way, it's important you prompt them that that's an acute exacerbation. They need to come and see you, or they may have to call 999, and they can take again up to 10 puffs. But also, you know, so you can review that at his next review. And he's also got, you said that he's on cetirizine, so he's got hay fever. So actually, hay fever might be a particular trigger for his asthma as well. So here it says asthma nurse. That might also be yourself, or they may have a dedicated or the practice nurse. So it's important to say when we gave him this plan, so because it forms part of clinical documentation, and when it should be reviewed. So as a minimum, we usually say to review it at least every year, but you might need to. So for this particular child who's having recurrent exacerbations, I mean, he's quite high risk, isn't he? And especially if you've got significant concerns about adherence, you may want to review it much, much sooner. So you might do it in 3 months or 3 to 6 months. So it's important that, or to specify, really specify to the family that if he has another acute exacerbation, it's reviewed again. Because like you said, he's already on quite a high dose of serotype. He may actually really need to be seen by secondary care clinicians. And then who he can contact. I mean, if he's just managed in primary care, that might just be putting down your practice number so that it's available. And if they are under secondary care, they may actually have an asthma nurse. Does that make it clear?
Yeah, that's really useful. Thank you.
Okay.